Hello, my name is Shannon Christy and my pronouns are she, her. I'm a behavioral scientist and an assistant member in the Department of Health Outcomes and Behavior at Moffitt Cancer Center. I am delighted to have the opportunity to speak to you today on the topic of addressing HPV-related cancer disparities among sexual and gender minority individuals. Here are my disclosures. I am an unpaid advisory board member for HPV Cancers Alliance, and the research that I present later in the presentation from my lab has been funded by the National Cancer Institute and Moffitt Cancer Center's Center for Immunization and Infection Research in Cancer. The National Cancer Institute has defined cancer disparities as adverse differences between certain population groups in cancer measures, such as incidence, prevalence, morbidity, mortality, survivorship, and quality of life after cancer treatment, burden of cancer or related health conditions, screening rates, and stage of diagnosis. These population groups may be characterized by race, ethnicity, disability, gender and sexual identity, geographic location, income, education, and other characteristics. Today, I'll be focused on HPV-related cancer disparities experienced by sexual and gender minority individuals. Next, I'll provide a brief overview of HPV and the HPV vaccine. HPV is the most common sexually transmitted infection, and there are more than 200 strains or types. HPV infects the epithelia, and there are several HPV types that are easily transmitted between sexual partners through anal sex, oral sex, vaginal sex, as well as intimate skin-to-skin contact and the sharing of sex toys during a sexual encounter. HPV is very common, and 8 out of 10 people will be infected with at least one HPV type during the course of their lifetime. Anyone can be infected with HPV regardless of their sex assigned at birth, gender identity, or sexual orientation. Most individuals who get HPV are infected soon after initial sexual activity, and therefore teens and young adults have the highest risk of acquiring HPV infections. However, infections with additional HPV types can happen with new sexual partners over the course of a lifetime. Consistent and correct condom use and use of dental dams can help lower the risk of HPV infection, but these methods do not completely prevent exposure to HPV. Usually, the immune system clears HPV infections on its own, typically within 2 years. Persistent HPV infections with high risk or oncogenic HPV types are linked to the development of 6 cancer types: oropharyngeal cancers, cervical cancers, anal cancers, penile cancers, vaginal cancers, and vulvar cancers. These cancers may not occur for years or even decades after someone is infected with an oncogenic HPV type. Infections from low-risk HPV types can lead to anogenital warts. And now a brief overview of the HPV vaccine. If age-eligible individuals received the HPV vaccine, 92% of HPV-related cancers could be prevented. The HPV vaccine is safe, effective, and offers long-lasting protection. The HPV vaccine is most effective in preventing cancer when it is given prior to sexual activity. However, the HPV vaccine can also protect individuals who have previously engaged in sexual activity or intimate skin-to-skin contact because they may not have been exposed to all of the HPV types for which the vaccine offers protection. And again, individuals may be exposed to additional types with new future sexual partners, and so it is important to protect your patients while they are still in the age range to receive the vaccine. Information about FDA approval and American Cancer Society and Advisory Committee on Immunization Practices recommendations can be found at the links shown. And here's the dosing schedule. Those ages 9 to 14 are recommended to get 2 doses, and those ages 15 and older, and those who are immunocompromised, are recommended to get 3 doses. And now some information about HPV and HPV-related cancer disparities among sexual and gender minority individuals. I'm going to use the term SGM as an abbreviation for sexual and gender minority. Others might use LGBT or LGBTQ or something else. First, some terminology. It is important to remember that each of these constructs are multidimensional and that the examples for the constructs are not exhaustive lists. Also, it is important to remember that terminology may change over time. Sex assigned at birth refers to the sex one was assigned based upon, for example, anatomy, hormones, and chromosomes when one was born. Examples include male, female, and intersex. Sexual orientation is a construct which includes emotional and romantic and physical attraction, identity, and behavior. Examples include gay, lesbian, bisexual, pansexual, asexual, queer, questioning, same-gender loving, and heterosexual, among others. Gender is a construct that includes gender identity and gender expression. Examples include male, female, non-binary, cisgender, transgender, and gender fluid, among others. This graph produced by Gallup shows that over time, the number of individuals identifying as SGM has been increasing. In 2021, 7.1% of the US adult population identified as SGM. This table shows that a higher proportion of those born in more recent generations identify as SGM. These include adults in the age range for whom the HPV vaccine is FDA approved. For example, approximately 1 in 5 individuals born between 1997 and 2003, that is those approximately ages 20 to 26 currently, identify as SGM. And more than 1 in 10 individuals born between 1981 and 1996, those about 27 to 42 years of age currently, identify as SGM. Next, let's talk about some of the HPV-related cancer disparities that exist. Prior research has suggested that SGM individuals may be at increased risk for some HPV-related cancers. For example, bisexual cisgender women have been found to be more likely to develop cervical cancer compared to cisgender women of other sexual orientations. Additionally, gay, bisexual, and other men who have sex with men are 17 times more likely to develop anal cancer compared to heterosexual men. However, findings vary by study and population, and more research is needed. Importantly, though, there is a lack of longitudinal sexual orientation and gender identity, cancer incidence, and mortality data, which limits exploration of these disparities. I do want to note a potential resource developed by the National Academies of Science, Engineering, and Medicine on measuring sex, gender identity, and sexual orientation, available via the link shown. In terms of rates of HPV vaccination among SGM subgroups, rates vary by research study due to who was included in the research, the location, and the year the data were collected, among other factors. Some studies have shown that SGM individuals may be less likely to receive the HPV vaccine compared to their cisgender heterosexual peers, while other studies have suggested that SGM individuals may be more likely to receive the HPV vaccine compared to their cisgender heterosexual peers. A study conducted among lesbian, bisexual, and other women who have sex with women found that 65% of participants ages 18 to 26 and 33% of participants ages 27 to 45 had initiated the HPV vaccine series. And a recent meta-analysis focused on sexual minority men found that on average, 37% of individuals had initiated the HPV vaccine series. The median from that meta-analysis was 26%, and the range was 5% to 100%, again, highlighting the fact that rates vary by study. Low rates of HPV vaccine have been found among transgender women and transgender men. There are a number of factors that have been found to be associated with HPV vaccine receipt among SGM individuals, including disclosure of sexual orientation or gender identity to one's healthcare provider, health beliefs and attitudes, access to healthcare services, and having a provider recommend the HPV vaccine, among others. These factors also suggest for whom additional interventions to overcome challenges to HPV vaccine may be needed. Provider recommendation is consistently among the most important factors associated with HPV vaccine uptake, including among SGM individuals. Sexual minority men who reported having a provider recommendation for HPV vaccine were 40 times more likely to have received the vaccine compared to those without a recommendation. However, prior research has suggested that provider recommendation may vary based upon patient sexual orientation. For example, lesbian women were less likely to receive a recommendation for HPV vaccine compared to cisgender women who had had no same-sex partners. Here are the current cervical cancer screening recommendations from the United States Preventative Services Task Force. These recommendations have been given an A grade and apply to people with a cervix. People with a cervix who fall within the age range for cervical cancer screening should be recommended for screening, regardless of their sexual orientation or gender identity. And here are the current cervical cancer screening recommendations from the American Cancer Society. Again, people with a cervix who fall within the age range for cervical cancer screening should be recommended for screening, regardless of their sexual orientation or gender identity. A number of disparities related to cervical cancer screening among SGM individuals have been identified. For example, transgender men are significantly less likely to receive Pap testing compared to cisgender women. And women who have had sex with women only were less likely to have had a pelvic exam and had fewer recent Pap tests compared to heterosexual women. In one study, participants reported reasons for not having had a recent Pap test, and they included barriers to access, such as lack of health insurance and being unaware of where to obtain a Pap, belief that it was unnecessary because they did not have sex with men, and prior negative Pap testing experiences. Providers can play a role in educating patients with a cervix about the importance of cervical cancer screening and the need for follow-up after an abnormal test. Here is some recent behavioral research conducted in my own lab. I'm going to discuss some formative work designed to inform the development of educational interventions. As part of a mixed methods study aimed at informing Spanish and English language education materials for young adult Hispanic or Latino sexual minority men, our team recently conducted an online survey among Spanish-speaking Latino sexual minority men ages 18 to 26 to characterize HPV knowledge, health beliefs, and healthcare experiences, such as the receipt of a recommendation for HPV vaccination. The data I'm going to present focus on one aim of the study, and specifically on the data from 102 unvaccinated individuals. Findings revealed that only 39% of participants reported that their primary care provider was aware of their sexual orientation. 79% of participants reported having heard of HPV, and 56% reported having heard of the HPV vaccine. But importantly, only 18.6% of participants reported having had a provider recommend the HPV vaccine to them. And again, these are unvaccinated individuals. However, 94% of participants reported they preferred to receive HPV education information from a healthcare provider. This highlights the importance of you as a provider and recommending the HPV vaccine to your patients. Our team also conducted another recent study, which was guided by the theory of planned behavior and health belief model, and included a series of individual interviews with young adults ages 18 to 26. We had developed a draft educational handout and asked for feedback on the draft's acceptability, accessibility, content, and aesthetics. We also asked for their thoughts on how to improve HPV vaccination among young adults, including best methods for delivering education about the vaccine. We conducted one set of individual interviews, then made adaptations to the handout based upon that feedback, and then conducted another set of individual interviews, and then further refined the handout based upon their feedback. In addition to the handout, based upon feedback received from the participants, we also developed a poster with the educational information. The majority of participants were assigned female sex at birth, had health insurance, and had had a healthcare visit in the past year. 40% of participants identified as a sexual minority individual. All participants had heard of HPV and the HPV vaccine. 60% reported having had a healthcare provider recommend the vaccine to them, and 80% reported being vaccinated. One of the study participants, a young woman who identified as gay, shared the following quote: "I know there's biases, like I said, but I'm a gay woman, and I try to be honest with my medical providers. A lot of the times, because I'm gay, they're like, okay, well, you don't have to have a pelvic exam. Okay, well, then you're not pregnant. I'm like, oh, all those things are cool, but I would still like to be fully checked out." I view this quote as being representative of the need for providers to recommend cervical cancer screening to their age-eligible patients who have a cervix, regardless of their patient's sexual orientation. And another quote: "When you talk about LGBTQ people, so many times because it's not penis and vaginal sex they've opted, that's kind of like the main definition that also providers are using for sex. Still, it hasn't adapted to be more inclusive when people are talking about sex. So I think that does confuse people. Even if you're trying to touch a bigger audience, things like toys and things that LGBTQ people are using can also be the transmission of the disease. But because sex is only taught one way, it's not, This speaks to the need for inclusive healthcare, and that providers may not be discussing the fact that there are multiple methods of HPV transmission with their patients. And in fact, that most people are at risk of being infected with one or more HPV types over the course of their lifetime. I want to conclude with some action items for you as a provider to do. These are things that you can do to reduce HPV-related cancer disparities and HPV-related cancers. First, it is to know what an important part you play in vaccination. Over and over again, provider recommendation is shown to be an incredibly important part of people getting the vaccine. Second, when discussing the benefits of HPV vaccine with your adult patients, include the prevention of anogenital warts and multiple cancer types. Third, consistently and strongly recommend the HPV vaccine to age-eligible patients with a presumptive recommendation. Fourth, encourage your patients to receive all recommended doses. Fifth, consider whether practice or system-level changes are needed, such as implementing reminder recall strategies. Sixth, recognize that certain population subgroups may experience unique challenges to receiving health care and may have had experiences of discrimination while doing so. Seventh, consider completing training to learn how to better provide culturally relevant and inclusive healthcare for SGM patients. Eighth, do not make assumptions about your patient's gender, sexual orientation, sex at birth, current sexual behaviors, and current number of sexual partners, as well as their past sexual experiences, especially if you haven't had a conversation with them on these topics. And finally, create an inclusive and welcoming healthcare environment, which can mean having inclusive signage and images in your clinic, asking about preferred pronouns and preferred name, allowing people to select more than one option when self-identifying their sexual orientation and gender, and having a write-in option for them to self-identify, including relationship status options that are inclusive of having multiple sexual partners, having staff and providers whose name tags include their pronouns, and having exam gowns that are available in colors other than pink and blue. I want to take a moment to recognize the many people with whom I have the privilege to work on a daily basis, as well as the study participants for the research that I presented from my lab, and the providers and other scientists who have been working in this space and are currently working in the space of SGM health. Here again are my funding acknowledgements. Thank you very much.